sort of our pitch about how to explain what we found, and then how to make a plan for management, which might include going back to wherever they came from if it's a long drive and being managed there, or if they want to keep making the trip back and forth to Morgantown, we can manage them here if that's a possibility. Did I say that right, Kirk?
Perfect. And so when we bring them back, we present, say that what our overall view was, which is that this patient is at risk for developing Alzheimer's disease in the future, even though he has normal function. So let me share the MRI scan right now. Share screen, here we go. So I'm not going to go through everything, but this is a coronal view of the patient's brain. And if we go forward on the patient's brain, you can see that in general, the sulci have maybe a slight amount of increased space where you see the a black spinal fluid, but in general, his brain looks pretty well preserved. But I'm going to go back a little bit and show you through this region right here. You can see his hippocampi bilaterally have a small degree of atrophy. So I don't know if I can point to this. Can you see my pointer?
Yes. Yes, we can see it.
So the hippocampi are right there, and there is a slight degree of atrophy. And so the other thing that's relevant is if we go further back in the brain, you can see that his parietal regions have larger sulci. And this is the very classic presentation, what you might expect with early Alzheimer's disease. So when we brought the patient back, we showed him these things and said that he had some mild consolidation issues. And the pattern on his MRI scan was suggestive, but not proof, that he may go on to develop Alzheimer's disease in the future. So the first thing that we talked about is therapy and what to do about this. And the first thing that I told him was that he shouldn't be using Benadryl. The second thing that I told him is that he will do better if he exercises, socializes, and adheres to a Mediterranean diet. Patients that have mild cognitive impairment are less likely to progress. These studies, the studies that first proved this, the one that I'm most impressed with is called the Finger study, done in Finland about 13 years ago was when it was published. And it demonstrated, after trying many different options for helping people that were senior citizens avoiding going on to have dementia, that exercise, socialization, and adhering to a Mediterranean diet all improve the likelihood of having healthy aging. So the next thing that we talked about was that because he did have a little difficulty and he noticed it, we started him on donepezil or /Aricept, which is a conventional treatment. Most primary care physicians and most neurologists tend to start it later than I do. And I'll explain why, why I started earlier. Aricept blocks the breakdown of acetylcholine, and it binds to two types of receptors. There are actually very complicated receptors with many different subunits, but they're basically divided into the muscarinic, nicotinic ones. I think the nicotinic ones are probably the ones that are most important in this case. And those, of course, as the name suggests, bind nicotine. Well, there's some interesting things you can know as a backstory. It turns out that people that smoke actually have somewhat lower risk of developing Alzheimer's disease. They die from other reasons, so I don't recommend people smoke. But there is this data out there, and it's somewhat controversial. But something that you would notice if you lived around a university campus is that people that are tired and trying to study and concentrate can do this better if they smoke. So if you look at the students on campus during final exam times, the ones that smoke start smoking a lot more. And so patients that increase their acetylcholine are stimulating the nicotine receptors, and they oftentimes report that they can concentrate and focus better. The downsides of prescribing donepezil/Aricept or any of the other cholinesterases is that it's like learning how to smoke. So if you ask a little boy what it was like to, when he stole his grandpa's cigar and went behind the house, he'll tell you he threw up. But if he stuck with it, he could learn how to smoke. And so cholinesterase inhibitors have that property. And so a lot of primary care physicians are not interested in prescribing these because they get phone calls about the side effects. But in fact, it's one of the things that's most likely to help that's pharmacologic that we can do. And so by giving them the patient some instructions, written instructions about what to expect, i.e. that nausea is common, that it usually gets better with time, that they can take a break. We usually start off with 5 milligrams and do that for at least a few weeks. You then can increase 10 milligrams. Some primary care physicians instead would prefer to just prescribe 5 milligrams and change the dose when they see them the next time. I oftentimes just say they can increase it if they're doing well. But the other things you have to know also is that it increases the risk of REM behavioral sleep disorder, vivid nightmares, and sometimes even daytime hallucinations. Most people prescribe donepezil at bedtime so that if they have some nausea, they sleep through it. But if that happens, if they have hallucinations, vivid dreams, or nightmares, they have to take it in the morning, and oftentimes it goes away. And so that's the first thing. The second thing that we recommended with our patient is that he was noticeably anxious when we saw him, and he was a little bit worried about how he was doing. And this is not an uncommon thing because the amygdala is right next to the hippocampus and is oftentimes affected at the same time. And so we frequently prescribe a low dose of Zoloft or sertraline. And it is, there's a number of SSRIs that have been used for anxiety. Lexapro is more common. I generally use sertraline at a low dose. The one thing that you should be aware of is that it can cause hyponatremia. It's not that common, but we tend to use a low dose. So in talking to our patient after telling him these pharmacologic and lifestyle interventions that he can make, we advised him that we could probably gain additional knowledge about whether he really was likely to progress. And so the MRI scan showed the physical shape of his brain, which was suggestive. And so the next step that we could do, if he was interested, was to do an FDG PET scan to look at the metabolic activity of his brain. And so I'm going to bring that up, but I'm sure it disappeared. Yep. So I'm going to have to take a few seconds to do that. Do you want to comment, Mark, about any other things that you commonly do or would want to do?
Yes. So, of course, it's important to find out whether our patients who are coming have a history of psychiatric care or not. But even if they don't, some of the things that bring them are the fact that their family is worried about them. We always try to be very specific about whose idea it was to come. Is the patient worried? Sometimes they say, I'm not really worried, but my wife thinks I have a problem. That's why I'm here. That's very important to discern. Most people are anxious about becoming dependent, and everyone has their own subjective experience learning about Alzheimer's disease. Much of it is very negative. I don't want to end up like so-and-so. One lady told me, I don't want to have Alzheimer's disease because my neighbor tried to make tea with a Brillo pad once. She was confused. And so that really frightened her. So finding out about what their subjective negative memories are is important to try to allay their fears and to decide whether they need a medication management for anxiety or depression, as well as their cognitive impairment. Kirk, are you up and running?
I'm up and running. I think you can see the PET scan. So this is a fluorodeoxyglucose PET scan, which shows glucose uptake. Base of the brain, the yellow and bright colors indicate increased metabolic activity. And I'm just going to sort of flow through the brain so you can get a sort of look at it and stop at a few places. So if we stop at this level, notice the frontal lobes are much brighter than the occipital and parietal lobes. And so this is an indication of hypometabolism in the parietal region, which corresponds to the place on the MRI where there was wider sulci. If we go down further, I went up. If you look here, you can notice the temporal lobes also have hypometabolism compared to the frontal lobes. And so the regions where we saw decreased activity, where we see decreased activity were the places we were concerned about the atrophy. And so this increases the likelihood that our patient is going to go on and progress to Alzheimer's disease, even though he doesn't have much in the way of symptoms right now. He's aware of them. This is not uncommon where people notice some subtleties about it. Generally, when we think about this, there's sort of a gray zone between normal, what's called subjective cognitive impairment, where we can't detect deficits, and mild cognitive impairment. And patients, particularly highly educated ones, very smart people, tend to notice differences, but they also are more inclined to notice, the subtleties of aging and attach more significance to them, particularly if they've been in a position to observe someone with Alzheimer's disease that caused them distress to see how they were doing. But with these two pieces of information, we informed the patient there was something else that we could consider doing. Biogen in June came out with, got FDA approval to give aducanumab or Aduhelm. Aduhelm is a biologic. It is a monoclonal antibody to help mobilize amyloid, which is one of the two major things that are seen in Alzheimer's disease. So in the pathology, the amyloid hypothesis is over 30 years ago. A friend of mine, Alison Goat, when she was a graduate student in John Hardy's lab, found mutations in the gene that codes for the amyloid precursor protein. And people that have some mutations of this gene go on to develop hereditary early Alzheimer's disease. And this launched the amyloid hypothesis, the idea that all you had to do was get rid of the amyloid and everything would be okay. It is somewhat controversial still. Most patients with Alzheimer's disease don't have a mutation in the precursor protein, yet they always have amyloid and they always have neurofibrillary tangles. The thing that makes it a little bit, pokes a hole a little bit in the idea that getting rid of the amyloid would fix everything is that one, patients usually don't have symptoms till they have neurofibrillary tangles. And mutations in the gene that codes for that actually cause dementia without plaques, the amyloid plaques. And so we also know that neurofibrillary tangles can spread from cell to cell, which might suggest if you have symptoms, it may be too late to do anything. One way to rationalize continuing to try this is to say that by having fewer places with concentrated amyloid, maybe there'll be fewer places where neurofibrillary tangles start. And so the next step to deciding whether someone is a candidate for using Aduhelm is to actually verify that they have amyloid in their brain. And so we did a PET scan as well as doing a lumbar puncture to look for the CSF amyloid tau ratio. Now I'm going to show you the amyloid scan, but of course I'm going to have to dig it up again. It'll take me a second. So while I'm doing that, there has been a lot of controversy about whether Aduhelm is a good idea. The drug was approved based on the demonstration that it clearly gets rid of the Aduhelm. A lot of the controversy about whether this drug should be given is based on the fact that the external advisory board was asked the question whether it was proven that Aduhelm actually made people better. And the data isn't convincing. In fact, the clinical trials to prove that weren't large enough and were suspended early enough that it couldn't be proven one way or the other. And so the other thing that's probably factored into a lot of people being angry is that there was probably too cozy a relationship between the FDA and the drug company, and there was probably undue influence by advocacy groups in the legislature to do something about Alzheimer's disease. That story is, not completely, we don't know about it completely, but it is something that is relevant. This is an FDG PET scan for amyloid. Dr. Hout just joined me. He's in his scrubs because he was down in the procedure. He usually likes to show people these images. And so I'm going to show you, go through this image to begin with. The first thing you need to know is the PET signal always binds to white matter. And so that doesn't mean anything. What you need to look for is whether there is amyloid on the surface cortex. And there is quite extensively here, 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 here. And this is one of the things that Dr. Hout likes to point out is this region around the cingulate that oftentimes shows increased, oh, something happened. Oh, I guess, shows that this can happen. So anyway, this patient elected to get Aduhelm and has now received his third dose of this condition. Among the things that we have to follow when we're taking care of this patient is to make sure that they don't have substantial inflammatory reactions from the drug. And so there's a dose escalation that happens with the infusions that occur over a year. In the clinical trials, they went out 18 months. And the MRIs need to be done before the 5th infusion and the 7th infusion to see there hasn't been inflammation that can become serious. The most common complications of using that patients notice from Aduhelm is there's occasional confusions, there's sometimes headaches, there's sometimes flu-like symptoms, which are common among all the biologics. And in the case of Aduhelm, some patients get diarrhea. The frequency of that is about 2% more than the frequency of people that received placebo. So it's not a big problem, but in fact, we've seen it in one of our patients. Mark, do you want to add anything?
Yeah, I'll add just a couple things. And it seems to be some people think that it's a balancing act between some of the side effects and whether the drug is actually working or not. There's a little bit of data to suggest that the drug is working if you get a little bit of inflammation or you see a little bit of microhemorrhage with some of the vessels, because that means the vessels are leaky. And so that some of the breakdown of the amyloid may be occurring and coming out of the brain. Of course, you don't want too much of that, but some people think it may be an indication that it's having an effect. The challenge with this is that, you know, we think if it's going to help somebody, it's going to be these very, very early patients who have very, very mild symptoms. You know, some of them don't progress for 4 to 5 years. So it's going to take a while to really be able to notice if it has an effect long-term or not. And so I guess the best news is that we have something to try, but we have to be very clear that we're just trying it. And we're trying to understand it and see what the outcome is for people. And if people are interested, that's great. But if they're not, then we really don't push it hard on anybody at all.
So I don't have much more that I want to say other than to ask if there's questions about the rationale for giving Aricept, sertraline, or Aduhelm.
I guess one of the questions I had, I mean, this is just from not having a medical background at all, but you talked a lot about how you would go into the patient, start that conversation. What is that typically like? Like, how do you broach that subject with them, even though, like you said, their medical history is pretty bland, you know, they're just seeing this. So you maybe give some background on how you would even start that conversation.
Well, you know, it is common prior to giving Aduhelm for people to just say everything's fine. And we have to wait and see. Patients are coming to us for answers, and we tell them that we're going to dig to see if we find anything wrong. And quite frankly, most people, when you start getting into it, were worried about how they were doing. Okay?
They came to see us for a reason. Usually when the symptoms are very mild, it's not because somebody drug them there to be seen. They wanted to be seen because they thought they could perceive something, you know, and that's exactly what we say to them. It used to be that, you know, years ago, if you came in complaining that maybe your memory was bad, then you were probably okay. If you knew enough to complain about it, you're probably okay. That thinking has clearly changed, and we tell them that that can be the first indicator. So we're going to dig for you. We're going to see if we come up with anything. And on most of the people that come in with that question, they're a better barometer. And so we start digging, and I would say 75% or more of the time, we find something. Sometimes we just have to watch, but sometimes it's like with this case right here, where clearly this was going down the path. He doesn't have a dementia at this point, but he was going to develop one. And so his signal brought him in. The testing was subtle. We tell him that, but let's keep digging if you want to. It's up to you how much you want to go. And if they came in, they want to go.
Because, you know, usually after the MR, we present our findings after the neuropsychologic testing, physical exam, and MRI. And basically, you know, the situation was they had the subtleties on MRI that we see with Alzheimer's disease. We showed them that. We tell them it is not a slam dunk that this is going to get worse because we only have one image at one point in time. And we can't really say from the neuropsychologic tests that they're going to get worse because we don't know what they were like 5 years ago or 10 years ago. And so, you know, but so there's a balance between trying to feed their anxiety that they're getting worse, when in fact they may just be having a moment. You know, lots of us have had the thing, well, at least my age, if you lose your keys, you wonder if it's the beginning of something. Okay. And if you lost that paper, or, you know, someone told you something and you forgot about it, you know, most of the time it's actually lack of attention to detail as opposed to actually something being wrong. But it is also can be the signs of something. And so people can get into this trap where they are overly vigilant for all the small faux pas they make. And so balancing between that and telling them, yes, we see something, or no, we don't see something, is pretty critical. And quite frankly, because we spend a lot of time with patients, patients are very trusting of us. And, you know, they say we're nice people, but I think they just haven't gotten to know us.
I'll keep that in mind if I can remember that. If I
like it.
You know.
Yeah, that's good to know. Good to know. So like when my husband forgets things, it's not, you know, concern. He's just not listening right now.
Well, I can't tell you that. But, you know, I know that I've been an absent-minded person since I was in, elementary school even. When I was in elementary school, they called me the absent-minded professor, the little professor, and I still am an absent-minded professor.
Sometimes just part of you, you know, I do think that it's important that you discuss people having anxiety about it, or people that have family members, like my grandfather. So if I tell my mom anything, she forgets something, and I'm not indicating she has something, I'm just like, I wish you would listen, or you're not remembering things. She gets really like emotional about it. So I think it's important to recognize that.
There's a phenomenon that's labeled now. It's called Dementia Worry. I reviewed a couple papers for it recently. And it's this concept that people have that they're going to develop dementia, because I saw it in my mom, or I saw it in my dad, or my grandma, or my grandfather, or my uncle. Everybody has known somebody who's going to develop a dementia. People always come in and say, I'm afraid I'm going to get dementia like my mom. Does it run in families? And we always say, yes, it runs in every family because the frequency is so great as you get older. But people have that worry, and they want to know, not just if they don't have something now, but if they do have something, so that they can understand it and plot a course forward. I think more important than any medicine that we give at this point is helping people understand the process. And we do that in great detail and explain why we think this and how we think this, and then what are the options to do this so they can make the decision. And that is really helpful for them and the family. It puts them at ease. And if you're at ease, your brain works better, for one, but it's just a better way to live life. And if you're anxious about having, or you have dementia worry now. And so taking that time and educating people thoroughly is the best medicine, if you ask me.
Unfortunately, of course, that's tough for primary care.
It is.
And so,
Alzheimer's Association can certainly help with that. We're also hopeful to help with that some in the future when we get to in-person support meetings also.
Yeah, I think I saw, Teresa, I think you tried to unmute. Did you have any comments or questions?
Oh, no,
I
was just going
to add.
We're always here to help.
Absolutely. Does anybody have any questions or comments or stories or anything they would like to share? None? Really?
I was just so clear.
You're just, yeah, you just hit that tail on that donkey. You did really good. Well, I didn't know about the Benadryl thing, so thanks for that. I used to do that when I was younger. I'm glad to know that. No one tells you that.
Well, actually, it's only been known from epidemiologic analysis for a few years. But it's not terribly surprising it would happen since, the cholinesterase drugs that help increase acetylcholine and the anticholinergics like Benadryl block it. So what do you expect?
What about, okay, like alcohol use? If you drink a lot, does that affect or impact your memory?
Well, that's a complicated question about how
I'm asking for a friend.
Yeah, so historically, the answer was that there's a J-type response curve and that one drink a day was considered optimal. More recently, based on an analysis called Mendelian randomization, which I happen to know a lot about, it's been concluded there is no safe level of alcohol. And I actually think the people that reached this conclusion violated some of the assumptions for using that approach. And besides, I don't want to drink alone.
And Kirk and I came to that conclusion at a bar as we were discussing the paper. So we're a little biased ourselves. I mean, like everything else, moderation is the key. Excessive drinking, excessive use of overuse of any kind of drugs, use of marijuana is not good for your brain. And if you have one condition that's affecting your brain, be it small vessel disease or the beginnings of Alzheimer's, anything else that you add to that will amplify it. And so for many patients who are developing the symptoms, we actually suggest that they cut back on their alcohol use, even if it's just one glass of wine a day, because it may optimize things for them in terms of their cognition.
In fact, we had a patient recently that drank a couple cocktails a day, and he got quite a bit better when he stopped. And that's not uncommon.
Yeah.
He had dementia and small vessel disease. I mean, he had dementia due to Alzheimer's and small vessel disease. So adding that a little bit of alcohol probably wasn't helpful to him. A lot of people drink alcohol because it relaxes them, and people with dementia tend to be anxious. They get anxious because they don't remember things. They get anxious because they get confused. They get anxious because they're worried about getting worse. And, as going back to one of the original points, it is common for us to add a low dose of an antidepressant, trying to make it better. Everyone remembers when they were in grade school when someone went to the chalkboard and tried to do a math problem and froze. It's because they got anxious. The brain stops working. And it still stops working when you get anxious. And so trying to smooth off some of the edges of that. And a lot of people, as they say, self-medicate with alcohol. And that's, something that we take into account.
Thank you for answering that. Mark, I see that you unmuted.
Yeah, I think it's worth mentioning, and maybe you can take up on this, Kirk or Mark, that with regard to Aduhelm, we often have the opposite problem of people calling in wanting it for their loved ones who already have dementia that's too far advanced to be eligible for the drug. So in this case, this gentleman came not knowing if he had a problem or not, and it turned out he did, and agreed to a trial of the medicine, which is who's an ideal candidate because he's so early. But when the damage has been done, they're no longer candidates for this drug. So we want to be clear about that for the people who call in and just vaguely heard about this and want it for their mother or father or aunt or uncle. So I think that's, and the other thing is cost, which we probably should mention what's involved if you have a patient who may be eligible for this, just so they know kind of what they're getting into. Do you guys want to just talk about that for a little bit?
How much the cost is for the average patient right now. If most people, the vast majority of people, if they had to pay for it out of pocket, wouldn't be able to afford it.
Because it's the cost of the drug plus the cost of once a month coming and sitting in an infusion chair. And so when you come sitting in an infusion chair, you're renting it from the hospital. And so you're going to pay for that rental and then the services you get then in addition to the cost of the drug. in addition to the cost of the MRIs that have to be done to check and make sure. So the cost kind of blossoms beyond just what the drug itself costs. You know, the thing that I talk to patients about who are interested in this drug, if they seem to be showing too much symptom right now, is, you know, the number one rule is we don't want to cause harm. We don't want to hurt you. And this is not a benign medication. And so just as we wouldn't give it to somebody who already has had bleeding in the brain, we don't want to risk somebody whose brain is much more fragile because they have much more effects of the disease. You can still have a good life and focus on that quality of life. It's that risk-benefit balance that I often talk with people about. And since so little is known about this, you would have much greater risk of having a bad outcome from this and minimal benefit potentially at all. And so we wouldn't be comfortable. Most people get that.
One of the things that we do in our center is we rely upon a consensus assessment that a patient qualifies. All of us has been in the position that we can be a soft touch of wanting to comply and allow family members to get, you know, to try anything when they're desperate. And it's hard to say no. And so, you know, people are willing to go to heroic measures even when they don't make sense to us. And so we rely on a consensus assessment to decide someone is an appropriate candidate. So if you refer someone to us for this, we're going to do our usual process to make sure that we all agree that it's a good thing to do.
And we had a clear discussion about this, that if somebody thinks somebody is being a soft touch and they're trying to get somebody in and they really shouldn't be in there, then it's everybody else's job to speak up and to offer their opinion, because we don't want to do any harm to people.
Thank you so much. Does anybody else have any comments or questions? Not seeing any. Do you have anything else to add? Dr. Williamson or Dr. Hott? Are you good? All right. So I just have one announcement. Our next session is going to be in November 9th, next week, and it'll be discussing medications and behavior. We also send a reminder out for that. And please, I implore you to bring your questions, case examples. That's what makes Echo Echo. So think of something, write them down, put on your little sticky note on your computer. Do what I do. So you don't have to hear my basic questions for friends. All right. Anyways, I hope everybody has a great day. And thank you so much for joining us.
Thanks, everyone.
Bye.